Welcome to MedHeads, the weekly show that brings a biopsychosocial focus to issues of the day, along with special guests who will showcase their expertise and enthusiasm about their field of practice. Your host, Dr. Fergal Armstrong.
Hello everyone, my name is Dr. Fergal Armstrong and welcome to MedHeads. And today we're very lucky to have with us Dr. Andrew Rees. Hello Andrew, how are you?
I'm very well, thanks Fergal.
Good. So, Andrew, this is the first time that you've done a MedHead show. I just want everyone to realize just how talented you are. So, can you give us a bit of a rundown of what your expertises are? And I say expertises rather than expertise.
Well, I don't know that I claim myself to be very much of an expert in much. I have an interest in some of the aspects of mental health, particularly the kind of psychosocial help that people need when they're perhaps dealing with chronic pain or with alcohol, other drugs, those sorts of things.
Yeah. So we've actually worked together quite extensively on a project that deals with the educational needs of other doctors. And in particular, you've made this contribution to that project in terms of your expertise with the psychosocial interventions that can be applied to patient care, especially in cohorts, as you say, such as addiction medicine and also in chronic pain. Isn't that right?
Yeah. So I find it to be very useful in those areas.
So how did you start into this journey, really?
Well, I have this curiosity in me, and I realized that I didn't know very much about any of this. I didn't really understand very much about alcohol and other drugs. And I suppose I had a fairly, perhaps even rigid view of the world about the whole idea that if somebody had a problem, you'd treat them with a medication and then they'd either get better or they didn't. I know that
I had that view too.
Yeah, I know that from my training, I had been taught the importance of the psycho and the social elements of helping your patients, and certainly being a nice doctor is something that you try to do. But I didn't really understand very much about this, and so I enrolled to do the opiate replacement therapy prescribers course, and then I started to dig a little bit deeper, and I became a member of our little group that gets together, and I started to learn more and more. And then I went digging for things like, well, how might, for example, acceptance and commitment therapy help somebody in chronic pain? And then that led to other things coming out of the woodwork, like how do you help people whose underlying problem is unresolved trauma? How do you help people who just don't seem to be able to find their way out of the woods? Those kinds of things.
Yeah. I mean, what you've said really resonates with me because, I can remember when I was going through my training, especially when statins came on board for the first time, and I think one of the first landmark trials was the WASCOPS study. And effectively, we were all told you can basically start statins and keep eating the cream buns. And, nothing could be further from the truth. And it's only really recently that I personally have become more informed and therefore I think more passionate about the role that non-medication interventions play in ameliorating suffering and optimizing health, not only for my patients, but also for me. The principles of lifestyle medicine I now apply to my own life. So yeah, I can understand when you say that it was all about the pills when we were both training, and now, as you say, it's different. So in terms of your experience of people suffering, what kind of suffering do you see?
Well, certainly I've recent times met quite a number of people, maybe not a great many, but a number of people who've had decades of chronic pain, treated with high dose opiates. and also people who have been struggling with alcohol and other drugs.
So would it be fair to say then that your main interest in this arena is about, prescription opioids and drugs and alcohol?
That benzodiazepines, and it also extends, I suppose, just to it's not so much whatever substance they're on, but whatever they're doing isn't working, and how might we best address their suffering? There's a lot of just plain, ordinary, but often awful problems with things like anxiety and depression that are not marked by any actual bodily pain that I also help people with.
I think, when I think about lifestyle interventions, I have now realized the importance of joy, the importance of purposeful activities and meaningful connections with other people. And certainly when I think about my former self, if I'd said that to my former self, I would have laughed at myself. That's when you're a junior doctor in training and you're trying to learn the 10 causes of finger clubbing or the 15 contraindications to sotalol. The idea that joy, meaningful connection, and purposeful activity can help people with ischemic heart disease, for instance, was just lunacy. But I think it's becoming more and more apparent that these kind of issues play a significant role in the maintenance of optimal health. What's been your experience of these issues, and how do you incorporate these things into your practice?
Well, certainly, I think hope is probably one of the cornerstones. Hope and connection are so important. Now, when I say connection, I do include, obviously, the connection with other people, but I also include connection with purposeful activity, connection with the environment, getting people to get outdoors, be not essentially one with nature, but at least go for a walk in the street, walk in the park, those kinds of things, get a bit of ordinary sunlight on themselves. Connection with things like a good diet is, I think, incredibly useful. You spoke about statins, and certainly if we can get people to have a diet rich in vegetables and exercise daily, avoid smoking, moderate or abstain from alcohol, we've pretty well done ourselves out of a job.
Well, I don't think we can say that.
Well,
yeah. Maybe we can do the cardiologist out of a job if everyone stops smoking, does some exercise, and eats a low-fat, whole foods, non-processed diet. But you've said two words to me that really chime. One of them is connection, and the other one is meaningful activity. Now, I mean, connection for me reminds me about the Johann Hariri book. Now, Johann Hariri wrote a very famous book called Chasing the Scream, which is all about his analysis and understanding of the world of addiction. But he also wrote a book called Lost Connections, wherein he described the causes, or the root causes of depression. And he identified two biological causes, which we won't go into. But then he started identifying other causes, which were all disconnections. So for instance, he said that disconnection from one's social group and one's work was a cause of depression. Disconnection from one's past, and by that he was referring to being a victim of trauma in one's past, especially as a child. Disconnection from socializing, disconnection from values, disconnection from work, disconnection from hope, disconnection from nature, disconnection from relationships. His key word was disconnection, and he felt that was a root cause for depression. And I suppose the corollary of that is that if you can start achieving a reconnection, then you can maybe ameliorate human suffering. And if we can turn it around its head and talk about depression, one of the things that he's also written in Chasing the Scream, he's also said that his view is that the opposite of addiction is not actually abstinence, it's actually reconnection. or connection with people. And certainly when we talk about recovery, I talk about a reconnection with people's former lives before they descended into addiction. So reconnection is a very important view for me, as is also, purposeful, meaningful activity. How do you feel about, teaching your patients how to reconnect and engage in activities like that?
Well, for me, it's not so much. I've moved perhaps from a fairly problem-based approach to helping people to move more of a solution-focused approach, and helping patients to recognize that they actually have quite incredible strengths, attributes, resources within themselves to make the desired change to achieve their desired future. Rather than me prescribing to them, you have to take these steps, or this must be your aim. I find that, well, first of all, for myself, as I work with my patients, I find it energizing because it's much more of a coaching role. One of the texts speaks of this analogy of playing a tennis match. And the standard counseling approach is that I stand on one side of the net and the patient on the other. I serve up my marvelous aces, and of course they're such wonderful shots that they have to just concede that I have all the wisdom. But then the problem is, in real life, I serve up what I think is an ace. It's an easy shot, and they drive it straight back in my face. So that becomes quite exhausting. A better approach is to actually join them on their side of the net and help them to make better shots and help them to enjoy greater successes. And it's just such simple things as recognizing that they've previously overcome things and they had an amazing ability in trying circumstances. Those kinds of things, picking out the exceptions in their story so they can see for themselves that they have this strength within. And then allowing them to choose their own path, allowing them to imagine their better future, their hope. That thing about hope is just so important. Without hope, people just remain very lost, and they will just go back and essentially anesthetize themselves with whatever substance they can find, or they will just collapse into the depths of despair. But if folks who have hope and that can see that the future is not fixed, but rather it's negotiable, and can imagine, can dream, that's another quote is from South Pacific. If you don't have a dream, then how will you know that your dreams come true? And so, getting people to actually imagine this better future, then seeing that they have the assets within themselves to achieve it, and then just letting them move off. And next time we see them, we'll talk about their successes, and that often really works. Another aspect, of course, in all of this is working with the plasticity of the human brain. So that, well, part of this is, first of all, giving them that hope by helping them to tell themselves about, in fact, they have these hidden treasures. And then another part of it is that when we're dealing with pain, realizing that pain is a protector rather than being an accurate measure of tissue damage. And that if we can, by means such as simple movement, reassure the patient that in fact they can move and that it's not doing them any damage, then that damps down their pain circuit. It no longer tells them that they have to be protected, and their pain fades quite rapidly. The same is true of things like depression and anxiety. We're talking to people and helping them to realize that what they're going through is in fact normal, expected. It's the way it's supposed to work, that it's not pathology, that in fact they can Take courage, have hope, and go out into the community, go out into the world, and engage in life, which I think is an essential part of that definition of health, is, you know, complete engagement in all of those wonderful facets of our lives.
So I'm hearing again reiterated this theme of reconnection. So you've spoken about reconnection with strength, reconnection with hope, reconnection with lives, reconnection with community. It's all about maintaining that connection. And so hope has got to be a function of how we connect, or for that matter, reconnect with all of the positive things in our lives. And I think I want to emphasize for those who might be watching this, that this is not wishy-washy mumbo jumbo. This is a really powerful stuff. And, you and I both work in the healthcare industry, and I'm sure you'd be able to give us, your personal stories of people who have made significant improvements in their health as a result of understanding the underlying importance of achieving this reconnection.
Well, indeed. I mean, to protect patient confidentiality, I'll sort of anonymize and perhaps give a typical picture of somebody that we might help. And can I say that it's not any great degree of genius on my part. I have spoken to some of my colleagues, some senior colleagues, some really rather junior colleagues, and they've all reported a degree of success with some of these simple measures. But the kinds of things that might be an example, something that might be an example, a person who had lived with chronic pain for over 20 years and had turned up religiously originally it was every 3 months, I think, and then it dropped down to a month, and then with recent PBS changes, it dropped down to every fortnight, to get their probably hyperalgesic dose of opiates prescribed to them. And
can you just explain what hyperalgesic doses mean?
Well, I think that these patients are often on well over 100 milligram equivalents of oral morphine daily. So we talk about the OMED, and an OMED of more than 100 is often associated with hyperalgesia, where the more opiate you take, the more pain you get. And that's my very simple take. So these people are often very mentally blunted. In the elderly, they're having falls, they're confused, they're incontinent, and they're really having quite low function. So my patient comes in, we have a discussion. I often use the rather excellent little animation of Tame the Beast by Lorimer Moseley. I think it's Taming the Beast, isn't it, by Lorimer Moseley. And I get them to have a look at that. And then we talk about pain theory a little bit. We examine the question of doing a little bit of movement. Sometimes, under these circumstances, I'm able to simply convince them that the movement is safe, this movement that they've forbidden themselves for decades. And with that knowledge, they will often then just go on and use it and get themselves a bit fitter and stronger. And then we might look at tapering their opiates. Some people have actually successfully gone off really quite surprisingly high doses of opiates quite quickly, and they've come back to me several times since, saying, I'm off all the opiates, I'm feeling so much better, I'm active. And it's often the case that they report that as soon as they ceased their opiates, the pain just disappeared. So
that's a really interesting message that you've got there, isn't it? That the painkillers that people have been using for numbers of years are actually now contributing to pain, and getting off these same painkillers is actually part of the solution for improving pain. A lot of people would look in askance if you said that to them, but it's now become part of the canonical wisdom that we now have developed, hasn't it?
Well, indeed. other things that are so important in this are things like attachment to values, reconnection with values.
Yeah.
And we touched briefly on that earlier. And when people have values, for example, like family, and we reduce their opiates, they're no longer blunted. They find themselves able to communicate with their family and enjoy their family's company, then they see that as being much more important. And the discomforts and the requirement for opiates seem to fade into the background, and it just seems to dissolve. But again, as they find themselves improving with very simple measures, of course, their own hope grows. I think really it's not that I'm giving a great deal of therapy. I'm just taking them gently by the hand and pointing them in a better direction. They find their own way out.
So reconnecting with family, with life, with hope can occur when we reduce the dose of medication that we're taking for pain. So for instance, when we do reduce the dose of opioids, that opens up possibilities that were otherwise closed to us. And I suppose it speaks to the toxicity that is associated with long-term opioid prescribing. I mean, they're not safe drugs, are they?
Well, certainly there's quite a level of overdose and subsequent death. But it's also not just that. It's this ongoing lack of function, loss of connection that flows from it. Whilst these people aren't clinically suffering from a substance use disorder, they have many of the components of that in their lives. Their conduct is wrapped around being able to get back to the doctor for the next prescription, making sure they don't run out of tablets and so on. And once they're freed up and they're doing multiple deadlifts every morning, and one of my patients came in and said to me, I went back and looked at that video again quite a few times, make sure I got your message right, doctor. And I'm doing my exercises every day. I had lost 5 kilograms without even trying, and all of those sorts of things, a much richer life.
Yeah. So what we're hearing, or what I'm hearing from you, is a reconnection, especially to hope, and allows us to kind of move away from dependence on pharmacological interventions, and allows us to become much more self-actualized, really. And it's a process that people should engage in without, with the ultimate destination being better function and more hope. That's what I'm hearing. Is that right?
Yeah, I think so. I think that my philosophy is one of active therapy. So active therapy means the patient has control. For example, when we plan out a plan for chronic diseases, I believe that we should be helping them to manage their own affairs and to be active in that, and to move, for example, is just so important.
Yeah, so I mean, one of my colleagues is a great believer in kind of lifestyle medicine in terms of managing pain, and he has a phrase: drug-free and free range. That's how he wants his patients to be when it comes to chronic pain. Because unfortunately, when we're talking about chronic pain, if we're defining it as pain that it continues beyond tissue healing, or for a duration of more than 3 months, we know that really the medications that we use don't really work. And if we do start getting reliant on drugs such as opioids, really, A, they don't work, and B, you end up with higher and higher doses. And then, as you say, we end up in this realm of opioid-induced hyperalgesia, whereby, as I've said before, that's the same pain-killing drugs that were used originally to dampen the pain are now contributing to worsening pain. So we don't have good tablets for a lot of these chronic suffering conditions, but we do know that lifestyle interventions can unlock the key to relief from that suffering. And it's trying to communicate that to patients that's the trick, isn't it? It's how do we actually sell that to our patients?
It is a difficult one. The road is made a little bit more risky by the fact that pain occurs in the brain, and so patients get attached on this idea that perhaps I think they're just making it up. And I
Yes.
don't. I acknowledge that their pain is very real. It is absolutely real. Unfortunately, their brain and perhaps their spinal cord has learned pain.
Yes.
And so we can help by getting them to unlearn pain. And I did mention also things like acceptance and commitment and mindfulness approaches and so on. And I've certainly found them to be also very beneficial in patients who are amenable to those kinds of approaches.
Yeah, and I think if we're moving into the discussing the realm of CNC pain, chronic non-cancer pain, and the pathophysiology, this concept that pain and chronic pain is learnt, and chronic pain lives in the spinal cord and the brain rather than in the place where it hurts. I reflect on some of my earlier patient interactions where I've said, oh, look, you've got this chronic pain, and the seat of chronic pain and suffering is in the brain. And then this patient of mine said, what, you're telling me it's all in my head? And of course that took the consultation in a direction that was not pleasant. But on a very simplistic level, it is important to understand that once tissue healing is completed, all suffering, all pain is in your head.
Yes.
And, the idea that you can, numb a nerve and therefore, or have an operation and therefore get rid of the part of your body that hurts, or at least numb the part of your body that hurts, doesn't always, in fact, more often than not, doesn't achieve the desired result. And if we're talking about, removing parts of the body that hurts, and then we're also then opening the Pandora's box into phantom limb pain, aren't we? So the idea that there's a needle or a knife that can actually cure people of their chronic pain, I don't doubt that some people have had benefit, but I do caution people into thinking that it's the panacea that they might otherwise consider it to be.
Yeah, and that's very difficult. The kind of approach that I often take is to give examples. So phantom limb pain is one, where you've got no limb to have pain in. Another good example is Ronald Reagan, who, when he was shot, commented that he'd played dying cowboys before and it was agonizing, but when he was shot in real life, it didn't hurt at all. And the famous story of the man who, getting a nail through his boot, screamed in pain, was taken to hospital by ambulance, and when they cut the boot off, they found it had passed between his toes and hadn't touched his tissue at all. But those pain perceptions are real. They are.
Well, listen, we are going to have to wrap things up because, unfortunately, as per usual, we always run out of time. And I really do look forward to the opportunity of discussing these issues with you again in the next show. But for the moment, Dr. Andrew Rees, thank you so much for sharing with us your wisdom. It's been a pleasure. Thank you very much.
Thank you.
My name's Dr. Fergal Armstrong. Thank you for watching MedHeads. We'll see you next time.